conference. So, do we know everybody? Should we do quick introductions? Would that help? Okay. I'll start. I'm Roger Olson. I'm the chair of this board.
I'm Lorelei Krasanik, board member. Long-time board member.
Peter Bohm, retired pediatrician and board member.
Also long-time, right? Christina Lee, board member, and I work for King Charles.
Andy Butler, board member, and I'm the clinical supervisor at Venture Missing.
Oh, okay. Nice to meet you, Lee. You're new to me, so good to meet you.
Michael Schultz, Sheriff's Office. I mainly assist with the corrections and the courts.
Have we met?
We have,
We see each other all the time.
right?
Dana Murray, the behavioral health administrative assistant for Chiefs County behavioral health.
I'm Janice Carso. I'm director of health services. I used to be director of behavioral, so I got to work with this board a lot.
Kristen Mazaki, program manager for the adult outpatient and the hubs.
Jess Nyworth, not a board member. I am the supervisor for the substance misuse prevention team and the public health side. Here in support of Janice as we talk about some of our overdose work.
Hi, I'm Julie McFarland, board member and business owner in.
I'm Melinda Thomas. I'm an attorney for High Desert Education Service District, and I focus my practice a lot on special education. And so I'm really interested in the work that you all are doing for behavioral health because it really has some overlap with what I do.
Okay, to the board. Or to the screen up there. We need to get closer camera. Y'all see me now?
Patty?
Yeah, Commissioner Dare.
Commissioner Adair, Patty Adair, just back from AOC.
Okay.
Kelly?
Guys, my name is Callie Rumley and I'm the behavior strategist at Fixsource for the Central Oregon region.
Hi, Paul Partridge, Program Manager for Deschutes Intellectual Developmental Disabilities Program. Apologize for not being there in person today.
Hi, Danielle McBain, board member. I am here as a parent of someone who accesses resources through behavioral health.
Liz.
Liz.
Sorry, I was trying to get my camera and my mic to unmute. I'm Liz Grotsky. I'm a mental health clinician with Mirror Pond Counseling. This is my third meeting that I've been able to attend thus far, and I plan to keep coming as long as you guys let me. Thank you.
Public meeting, you're always welcome.
Thank you. I appreciate it.
I didn't, sorry. I came in late. Amber Clegg, a clinical program manager here for our behavioral health department. Everybody.
Okay. Well, thank you for inviting me. It is really nice to see some of you. It's been a while. So I was asked, and I hope I am addressing the things that Roger had hoped I would address, but I was asked to come because you've gotten some information over the last few meetings about how the opioid and fentanyl crisis is presenting in our community. And there was a Metcon 10 presentation, or was there not? I'm going to cover it a little bit. And he asked me to really talk about what are we doing now and what's on the horizon to address the fentanyl crisis. So is that what you all were expecting? Okay, so I'm going to run the slides if that's okay. And let me just back up and say that that's Jess's name in print so that you guys recognize who she is, but she's a public health partner. And her team and our overdose prevention and response team are working very closely now, I believe meeting weekly now, yes, to strategize, plan, and coordinate our response when we know there are spikes and other things. So just kind of anchoring These are abbreviations. I'm not going to go over them. It's just a chance for you to see that some abbreviations are used. If you want to know more about one, just let me know. So I'm reviewing what Matthew, our epidemiologist, spoke with you about, I think 2 meetings ago. Just kind of setting the table again. We know that preliminary data for July, as of July 2023, continues to demonstrate an increase in drug overdose mortality, higher than in 2022, which was higher than 21, which is higher than that has been consistent across the country. So overdose rates are increasing across the country. And I'm sure you guys talked about the fact that a lot of that increase is really being attributed at this point to fentanyl and the presence of fentanyl in the market and in other substances that people may be using recreationally and not realizing are contaminating their health. Treatment resources remain thin in spite of investments. So when I say treatment resources are thin, I'm talking about things like long-term residential treatment, hospital level of care, recovery housing, sober housing, and even transitional housing for people that have recovered. And some of the other challenges include timely mortality data, coordinated response, rapid access to treatment and harm reduction, making sure that that's available in every community and robustly available, because we know from states in the East that when those things were present, they were better able to respond to and address and reduce mortality from the opioid crisis. So I want to talk a little bit about what we are doing and have been doing for some time to address overdose and addiction and mortality, and then talk about some of the outcomes of that. And I think I'm actually going to let you guys watch this video because it is such a good video. The Pain Standards Task Force has been in place for how many years? Who knows? I think since 2014, maybe not quite, but that's the, for those of you who don't think about this all the time, the opioid epidemic really got launched by problematic prescribing practices and problematic pharmaceutical practices. So if you look at some of the data, people that have opioid addiction will report at the rate of about 70%, depending on the study, that their first use was actually a prescribed opioid. So overprescribing was early on identified as a critical part of what was contributing to this increase in addiction to opioids and then addiction to street drugs as people needed more or were no longer being prescribed opioids. So the Pain Standards Task Force was developed as a way to really help Oregon doctors and physicians better manage their prescribing practices and develop other ways for people to manage pain. Because of that work, there's been a 41% decrease in problematic prescribing practices in Oregon over time, which is pretty profound. Cooper, Central Oregon Overdose Prevention and Response Network. That only took you like 6 months. Is a group that was convened to address overdose in Central Oregon. And that group meets regularly. I think Katie Plum really helps drive that group. Katie Plum is the public health director for Crook County, and Crook County got a grant to develop a surveillance dashboard to do real-time surveillance on overdose mortality and overdose rates. The hope is that, and this is one of the things I'll be forecasting into the future, that they can begin to get some collaboration from first responders and the EMS and the ED on putting some information into the database so we have better local real-time information about who is ODing and where and on what. But that dashboard is under construction, and Cooper does other things as well, like educating people about naloxone, getting naloxone into the community, etc. The toolkit is even now being used, even though it's not in its final form. It's being used every week by our team to pay attention to where overdose is happening, what is it on. Public health prevention has done a lot of public messaging You will get this PowerPoint, the links work, so you can go to every single one of those links and listen to or see the information that's being put out there about responsible use of prescribed medications, the risks of fentanyl, the risks of taking drugs that were not prescribed to you, because again, some of them may contain fentanyl, or it's risky behavior regardless. The Upshift program helped produce this video with some Bend high school students to talk about fentanyl, and we're going to watch it in a moment. And our emergency preparedness function within public health also now will become increasingly involved in taking the data that we learned from Cooper and real-time surveillance and beginning to develop health alerts that can go to the community and say, hey, this is what we're observing. So let's see if I can get this to work. Are we on audio mode? So I think should work. Now remember, these are not professional actors. They are high school kids. They're adorable.
Kids.
Yeah, local kids. Oops, sorry. Play nice. But some really good messaging there. Fact-based, and it was just nice to see kids who were
Where is it being shared?
being shared by all over the school. I have shared it broadly. You can share it with, I actually really encourage you to send this to anybody you know with you. This is made by you, for you. It can be shared broadly, and it's got really important safe messaging in there. And I encourage you to carry Narcan. I do. So, right now, in my bag. So, figure out where to find some and put it in your bag. You might actually save a life. It might be a family member's, unfortunately. That is a possibility. So, okay. So other things that are happening that have been positive is, of course, our certified community behavioral health clinics, which provide comprehensive mental health and substance use disorder services. The integration with primary care has been particularly powerful because all of our primary care providers at this point are able to provide are certified to provide medically assisted treatment, meaning buprenorphine or other long-acting. They can provide long-acting. You will know what is the long term for long-acting buprenorphine injectable? Sublocade. So all of our Medicaid or all of our primary care providers provide Sublocade, which is a monthly injection to address opioid addiction that's been really effective at helping people stay clean and sober and maintain their recovery. Our harm reduction program has been operating for quite some time. We've added hepatitis C outreach testing to that. And we have doubled and probably more than doubled at this point our distribution from naloxone into the community, and had an enormous number of people reporting that they have recovered from overdose as a result of those supplies. Homeless outreach services team was expanded through ARPA funds and Measure 110 dollars. So it went from a team of 2 to a team of it's either 9 or 11. I can never totally remember. But that team is also doing lots to connect with people who are at risk, in particular of mental health disorders, but also sometimes struggling with addiction. And last, the Stabilization Center sees people every day, all day long. About 40% of those people have co-occurring mental health and substance use disorders. We have referrals to treatment on site. We can help with warm handoffs. Obviously, we have naloxone available in case of overdose, and we work closely with our law enforcement partners and our with the population served there. So, as you all know, we also have added to the array of things in this community resources that came to us because of Measure 110. The resources come in what's called a Behavioral Health Resource Network grant. So Measure 110 was the measure, and the burns are the vehicles through which the dollars distributed into the community to provide enhanced outreach, engagement, and treatment resources for people really on the high end of risk for serious outcomes from addiction. So the goal of Burns is to increase rapid access to treatment, rapid access in particular to medically supported recovery, meaning detox and medically assisted treatment, increase harm reduction supplies like naloxone, syringe exchange, fentanyl testing, strips, employment counseling, housing vouchers, supplies for houseless individuals, and intensive outreach and peer supports. In Deschutes County, this is just an image of what we have. I did check the amounts that were funded on the Measure 110 dashboard today. So these amounts should be accurate. If they're not, it's because the dashboard is not accurate. But Best Care was really the driving entity for our burn application. They applied for all 3 counties because Best Care is in all 3 counties, and we applied with them in their Deschutes County application. So we were funded Ideal Option, which is a peer outreach program, Rimrock Trails, a youth serving substance use disorder program, Boulder Care, a telehealth MAT provider, and Healing Reins, which you're all probably familiar with, but is a therapeutic riding program. All of those programs got funded under Measure 110. I put links to the dashboard in there so you can go and just look. And I also put links to the Health Justice Recovery Alliance website and dashboard so that you can sort of look at the organization that has worked very closely on the Measure 110 initiative. I thought it might be important to share just some facts and information about what we know so far about the impact of Measure 110. So there's good news and not good news. The good news is that there just was a report released literally this last month, September. Oh, that was 2 months ago. Wow. Wow. So that report showed that based on provider reports, there was a 365% increase in client gains around connecting with supported employment. So people that were being served had a 365% increase in being connected to some form of supported employment resource. 190% gains reported by providers around housing resources for clients. Over 7,000 people received substance use disorder treatment at that time. That was after 3/4 of burn activity. And that's 104% increase over the 3/4 period from baseline. Over 47,000 service encounters occurred, meaning individual contacts with someone with a substance use disorder who was seeking treatment, and that's an increase of about 134%. There was a recent study released by the New York University, New York University, yeah, okay, School of Medicine, and they looked at whether or not there was a statistical positive link between the period of time when Measure 110 went into effect, meaning decriminalization in Washington and Oregon, and increases in overdose rates. And what they found is overdose rates increased throughout the country. They did not increase statistically more in Washington or Oregon between when Measure 110 went into effect and March of 2022. So we are now in November. We probably need another look at the data. Overdose has gone up across the country this year. We don't know if that same phenomenon is still true. It would be worth asking, but the initial look was, yes, overdoses went up. They didn't go up any more in Oregon than anywhere else, or in Washington any more than anywhere else in 2022. Drug arrests decreased, obviously, because when you decriminalize, drug arrests will decrease. Violent crime arrests did not increase. Again, this is looking at data, I think through July of 2023, that particular piece of information. Ongoing questions and concerns, again, we know that fentanyl overdoses in particular went up dramatically, especially among youth in 2023. It's unclear how that phenomenon would impact the findings of the study. So we still have questions about that. The other thing we know is that all of the burn partners across the state are reporting the same thing about still needing more access to detox, still needing more access to treatment, still needing more access to sober and recovery housing. So Measure 110 or burn resources really flooded the system with resources to intensively engage with people and connect with them and try to build relationships, get them into treatment. But it didn't necessarily increase the amount of treatment available. A little bit, but not as much as probably was needed. And then there are still obviously questions about the longer term results of decriminalization and what that's going to look like in 2 years, 5 years, 10 years. So those are some of the knowns and unknowns. Okay. Okay, so we'll talk a little bit about some resources we just added. So we did co-apply really with the county for the opioid settlement dollars with probation and parole. So we submitted an application to the county to say, here's what we would do, here's what we would propose to do with opioid settlement dollars. Remember that pharmacies lost huge lawsuits as a result of the opioid crisis, and dollars distributed to states and counties to really make them whole from the ways that their citizens and community members were damaged by the really overwhelming number of deaths that resulted from the opioid crisis. We're probably getting close to 700,000 people at this point. More people than died in the Vietnam War. That's a lot of people. So we proposed a 5-year strategy to add targeted expert overdose use prevention, expand coordination of surveillance and overdose prevention activities, sustain existing crisis interventions, add direct case management and coordination for a forensic population, and add recovery peer intervention services. So those are the kind of the broad categories that cover prevention, surveillance, and intervention. So what that looks like is we added positions and resources in our targeted prevention, surveillance, and coordination. The goals were, what you see at the top are the allowable uses for opioid settlement dollars that came out of Exhibit E, a famous Exhibit E. Exhibit E was this multi-page exhibit in the legal filing in the settlement that said, here's what you can use this money for. We will be using it to continue to improve awareness and utilization of resources around opioid use, prevent and reduce adolescent and young adult drug use, improve coordination with internal and external entities working to reduce overdose deaths and harms, and ensure real-time surveillance. So the actual concrete outcomes are that we will have a regular ongoing way to use our emergency preparedness program and our Cooper data to make the public aware of where the risks are and with overdose rates. The new staff and the team that is being supported by our supervisor, Jess, will be doing the goals to provide overdose education and resources to 10 organizations in the community that are engaged with high-risk populations. So newly emerging treatment providers, peer-run organizations, places like the Loft, places like that where you really want to reach people that are maybe not reachable in more traditional ways and are really at high risk. Develop a website on how to receive naloxone training and supplies that's local. You can look at the OHA one, but that is not a local resource. Develop a network of agencies who ensure that access to naloxone is available in the community. We're already probably 2/3 of the way there. Launch the surveillance tool to communicate overdose deaths in a timely manner. And I really want to pause there because I want to hear what Jess has to say about the Cooper tool and where we're at and what we're anticipating.
Yeah, so the surveillance tool, we have a overdose review board between public health and behavioral health partners that we've been meeting weekly to create this tool. We've actually based it on the SCRAP tool, which is something the medical examiner uses currently to meet legislative requirements about reporting suicide deaths. And so the medical examiner has a tool they use anytime someone comes in. It's been determined this is a suicide death and records a number of pieces of information that help us not only track what is happening from an epidemiological standpoint, but also helping us to understand how we can best do post-vention, which is how we reach out to the community around this person who has died. Because we know that often there are more suicide fatalities after one in a group of people. Similar, we see overdose about someone who is maybe has access to this bad batch of drugs or is accessing these drugs, needs more resources. So we've set up this system called DOMS. We love our acronyms, right? And it actually will be live at the beginning of this next month. We'll be able to start receiving data from the medical examiners and investigators about what we're seeing in our overdose fatalities here in the county.
And we're struggling to get EMS to put data in stuff, right?
So we'll have to, we're starting with the medical examiner for fatalities. We are starting a bit to get EMS data. It's a little of a clunkier system.
Yeah.
And so that is our next stage.
Yeah.
Of data surveillance.
And are we making progress with having more consistent and robust testing for what substances in the tox, post-mortem tox testing?
Yeah, that is something that is probably going to have to happen in Tri-County
Okay.
focus, because there are such new emerging substances, and I'm sure Michael knows, every time a substance comes up and is known, there's a slight molecule change. And so how do we make sure we're accounting for that in our toxicology? And some of these new reports, these tests are expensive. And so making sure that we are making that a priority and a requirement for all of the suspected overdose cases.
And that's really critical because it's important for us to know what are the substances that are leading to overdose. There's been a lot of conversation and noise about xylazine, which is a animal tranquilizer that has shown up on the East Coast. And there were some rumors that it was here. It is not showing up in the overdose and mortality tox screens at this point in any significant way. Now, that there are no guarantees that means it's not going to begin to show up, but it's a way for us to continue to provide factual information to the community about what's actually happening and what is not happening, and manage some of the noise that can happen around these subjects because they're scary. Okay,
And
so
honestly, actually,
yeah.
sorry, I want to jump in. Some of the best real-time data we're getting as of now, besides coming from our ME and our Essence data from the emergency departments, is through our harm reduction program.
Right.
They get reports because they have such trusted relationships with their clients and with community members who are using these services. They get reports of overdoses and use of Narcan, how much Narcan is being used, and did they call emergency services? And so we're able to actually track those cases through our systems and have real-time data reports of what is suspected to be in that product, and then being able to track it on the back end.
Thanks, Jess. The other section of the use of the opioid dollars is focused more on intervention. The goal are to divert people from the ED and the criminal justice system, prevent overdose and suicide deaths, connect individuals with treatment and help them stabilize, and provide coordinated focused case management services to a community justice population. The proposed outcomes are, and what that really did was put some dollars towards the stabilization center and some dollars towards a contract with a peer-run organization that's going to work directly with probation and parole on people who have recently released from incarceration who are at very high risk for relapse and overdose. So we'll be in the stabilization center, we're going to be developing a workflow to document crisis SUD treatment referrals, so we can actually track how many of those are occurring and whether or not people follow through. Establish a crisis SUD referral baseline in 2025 and an improvement target for 2026. Increase pre and post release access to peer-based entry and pre and post release from incarceral settings. That's what that refers to. Ensure culturally responsive peer-delivered services and reduced visits to the stabilization center, the emergency department, and jail for overdose. Just see if we're tracking that is decreasing as an emergency sort of response in the community. So where are we headed? What we're working on now is there's a small team in behavioral health. We have a new psychiatrist, Ann Linton. I don't know if any of you have met her. She is quite amazing. She is a triple certified psychiatrist. She had certification in SUD, psychiatry, and she's a medical physician. She worked for the Betty Ford Center. She pioneered buprenorphine treatment when it was still a what the heck are you talking about, Willis thing. So she's been quite amazing, and we're super lucky to have her. And she is really excited about looking at becoming certified to provide MAT for those patients who will not go to primary care. and who are really engaged with us and might actually be willing to consider MAT if they're working with us. And by the way, our population of individuals who identify opioids as their first choice drug is very small in behavioral health. They are mostly still impacted by alcohol, which still kills hundreds of thousands more people than opioids do. Please don't forget that, nationally and in Oregon. And methamphetamine. And the problem with methamphetamine right now is that the cartels are mixing fentanyl into other substances like methamphetamine, quite frankly, to increase the market for fentanyl because it creates addiction so quickly. And so people who have been historically addicted to methamphetamines are now becoming dually addicted to opioids, fentanyl, and meth. And it's a really awful combination. And can lead to some pretty acute psychoses that often do not resolve months or years after use discontinues, which is really tragic. Sorry, that was a bit of a tangent, but we worry about that. We are exploring adding a peer, a recovery mentor peer specifically to the Bend ED at St. Charles. The other EDs have had that because of Best Care's work in Redmond and Madras and Cook County, but Bend has not had that. We are recruiting right now and hope to hire an overdose prevention and response coordinator that was made possible by the opioid dollars. So we will have a specific expert on opioid overdose prevention in public health. The real-time data system, surveillance system is launching in December, which is amazing. And we are just now starting a collaboration with our CCO, Dr. Jeff Davis. I always want to say Daniels. I think it's Davis. Is it Davis? Davis. Jeffrey Davis is bringing together some of the treatment providers and healthcare providers on the more direct treatment side to really look at how we coordinate across our systems to address the opioid crisis. So I literally have to run out of here in 5 minutes. I feel like I've never talked faster in my life.
It was excellent.
That was a lot of information. All those links, so sorry, the next slide, all these links I believe are live. So you can go and find, this is the link to the article I talked about that released some initial data on whether or not ODs increased when Measure 110 went into effect. What questions could Jess or I answer while we have a couple?
Yeah, and I'll be here.
Okay, you're gonna stay. That's
Yeah, good.
one of my questions was a lot for you, I guess. I don't think Janice would leave. We talked about and harm reduction was here last month and talked to us a bit. So is there data, I'm gonna call it anecdotal, will that ever be reflected in like the statewide statistics and things like that if they're not recorded somewhere else?
The harm reduction data?
Yeah, I mean, just like you said, they have personal relationships with some of these people and they get information, but it's not documented anywhere.
Yeah, that's a good question. I think historically public health is pretty hesitant to report anecdotal data. Partly because of this focus on surveillance and epidemiological responses and having consistent tracking and reporting across counties. So I don't anticipate that anecdotal data will show up in, say, an OHA report, but we are, part of the work they've done is created like tri-county or multi-county coordinators, and we share amongst ourselves and they share amongst each other. So this information is spread really widely, including working with law enforcement, working with HIDA, and what they're seeing in kind of the supply world, and making sure that our ED and our EMS data is also a part of that conversation of trying to get ahead of the trends, as well as making sure that we are responding appropriately on the ground and in the long term. So we will see it likely in the county and the tri-county area, but I wouldn't expect to see it in the state.
You know, I'm
And they're-
very important information. I mean, that's really what Boots on the Ground's all about, but
That team was asked by the board actually to provide a report on overdose, on distribution of naloxone, distribution of fentanyl test strips, overdose, self-reported overdose rates, all the data they collect right now. So that will be available quarterly. Anna Woodburn was just finishing a template for that she shared with me. So there will be a quarterly report internally, locally to our board, and any of you who want to see it, that would be available. Yes, sir.
So yes or no? Because you have to leave.
Yeah.
You have plans for next year too.
Do I what?
So do you have plans for next year to continue this work?
For next year?
Yeah.
You mean the projects here?
Yeah.
Oh, yeah. Like other plans other than the ones we just talked about? Or are you asking me if I'm staying? I'm not sure what you're asking.
You know, if you have a question that you want a yes or no answer to, it's tricky, isn't it?
Yes. Yes, are we planning to continue this work? We're gonna have to. People are dying.
Yeah, and there's
Choice.
more money coming. When is the next settlement fund coming?
I have no idea.
So I think there's more money coming in the system. It's amazing. We talked last week in my presentation, we talked about how, 4 years ago, all we were talking about is mentally ill individuals and try to divert them from incarceration and provide experience. Now, all we talk about is drug addiction. And we're seeing it everywhere. In fact, hardly ever do we talk about, especially in criminal justice system is mentally ill, because I think we've done a good job at diverting that population. Maybe not.
No.
Yeah, because I don't see it and I don't have to deal with it as much being in charge, but I deal with the opioid addiction every single day. Last night, this morning, every call is, this is what we have going on. So, and we know some of it is just a lack of providers, and hopefully with more money coming in, we can make a dent on that and start moving people out of areas of vulnerability.
One of the most unfortunate things that I think has happened in the treatment world is the separation of mental illness from addiction. No therapist considers them two separate things.
I'm glad to hear that, because we don't either.
No therapist who's done this work for any length of time thinks of addiction and mental illness as something that happens in isolation of each other. One of the things we know from research is that a lot of people with serious addiction have histories of profound trauma, have very high ACE scores, adverse childhood events, have often had emerging mental illness, symptoms of serious mental illness in adolescence and young adulthood that sort of track right along with their substance use. So we know that those two go hand in hand. And one of the real flaws in our system is that we've treated them separately, and we've done people an enormous disservice, because the response that the community has to people with addiction is often a shame-based response, and the response that people have to mental illness is often a health and recovery response. And we need health and recovery to be the response across the board. Addicts know that what they're doing is terrible. They do not need anyone else to tell them that. What they need is help and recovery and supports and resources. And it doesn't mean everyone's going to recover, and it doesn't mean there aren't bad actors out there. Not gilding the lily at all, but that's what they really need. We have a really easy time, we do better when we think of people as being mentally ill. And when we don't really understand the link between mental illness, childhood trauma, poverty, incarceration, and all of these things on the factors that really lead to chronic addiction, we just don't understand how to treat that problem right. We can't punish our way out of it. I mean, there are people who deserve punishment because they've done terrible things to others.
They do something.
Period. But that alone doesn't prevent addiction. And we know that because people get out of prison and they overdose, or they continue to use, or they relapse. So I'm on a little bit of a soapbox, but it's really distressing to me because if you talk to any of my clinicians, they'll tell you that somewhere between 70 and 90% of the people that we treat for a mental health condition are probably struggling with substances on some level, whether in their own life or in the lives of people around them, and they've been impacted by that. And we're treating it as a separate problem, and it's just not. And so people go to substance use treatment, and some of the more purist treatment agencies won't address their depression or their trauma history. And so they suffer the consequences of those very significant mental health disorders without support or care. And guess what they do when they get out? They relapse. So, so lots to think about. Jeff's is a wealth of resources. I can send you articles. We have amazing people doing this work every day. Our harm reduction folks and our homeless outreach folks are probably touching 10 to 30 people a day when they're out there in the community. So it's pretty profound. Thanks you all for your time.
Thank you for your time.
Yes.
Really appreciate
You all. I'm glad you're interested in this. It's so
Well, it's a pretty big issue.
it is a big issue.
And I'd like to know how we can collaborate more with public health, I guess, so we get, you know.
We should do a joint PHAB BHAB, one on houselessness and one on addiction.
Okay.
Let's do that all the time. Can you talk to, I'll talk to Heather about it. All right. Have a great Thanksgiving.
Okay, thank you. Thanks again, Jen.
Yeah.
Any more questions that we can freshen everybody's mind?
Yes, please, I have a question. I sit on the SUD work group with the Health Council, and so Casey Shaw is in that. So I
He's our regional wellness coordinator.
yeah, so I'm trying to understand, because I saw on the one of the slides was about Deschutes County also having a regional overdose prevention coordinator, or like, are we moving towards more of a regional response, or is it still kind of county by county?
So what we're doing, yeah, yes, good question. So we're in the midst of hiring a county overdose coordinator. So that's kind of to get all of our surveillance system ducks in a row.
Yeah.
To do the legwork of reaching out to EMS and making sure we can track that data and running down cases and expanding our naloxone and Narcan outreach and education to beyond kind of the houseless community and you know, to other individuals who are using substances but aren't being served yet. And also to do communications work, so social norming, probably some education campaigns, and what does it look like upstream prevention for adolescents. So they're going to be doing like Deschutes County like coordination. And then also will be our point person with the Tri-County area, because we know that people don't live, work, play within county boundaries, right? And so we've got people who are traveling between counties on a daily basis. It doesn't make sense for us to only look at our county, but to work in a Tri-County way, making sure we're also talking to other folks, because it's coming up from K-Falls. So the opioid crisis has come east to west and then south to north to us. So we have a lot of lessons learned that we're able to kind of tackle and pick up quickly. One of those is having a regional response and regional coordination. And actually, I was responding to a text between our county folks earlier about, you know, suspected overdose fatalities that have crossed county lines. So we're working on a weekly, likely or bi-weekly kind of data report, and then we have very similar risk communications that go out to one another.
Interesting. Thank you.
I would see it in the frame of like emergency preparedness is what we kind of do on a Tri-County model.
Yeah, there's some questions on the chat. There is one new one, sorry. I've been monitoring them on my screen. Okay, guys, just saying bye. Okay.
Now, everybody should have got a copy of this PowerPoint and other stuff. If you weren't your office earlier this morning before you came to this meeting, you might have missed it, but everybody, and same with you people on Zoom, that you should have a copy of that available. If you don't, Dana will send it to you. Exciting. I'd like to see this Tri-County work, the regional work is really so important to everything we do in this.
It's really necessary. We have a lot of resources in Deschutes County. We also have a larger population. And so there are pros and cons that come with that. One of the pros is we have quite a bit of ability to create an infrastructure using best practices and make it happen quickly. And we're able to share that with our Tri-County partners as well as learn from their experience. So it's needed.
If you have any questions about that, just sit on 97 up there at Redmond sometime and see how much traffic's going both directions every morning and every evening and back and forth. It's pretty amazing. Anything else on this?
I'll stick around. If you have any questions afterwards, happy to answer them, but I'll sit quietly for the rest of your meeting.
Roger?
Oh.
Yes.
I'm sorry to interrupt. I guess before you move on, I guess I did have a quick question about, you mentioned something about Narcan in the schools, and I'm wondering how receptive schools have been to having that with the nurse's office, and is that available in other parts of different schools, or how has that been implemented, and how are you feeling about it?
Yeah, I would say, so it's a requirement now for schools to have naloxone or Narcan in the nurse's office. And I would say it's probably a mixed reaction, depending on each individual school. I would say overwhelmingly we didn't get as much pushback as we were expecting. And we have such a strong connection with our school system in Bedford Pines, particularly because of the Healthy Schools program, that we have a warm contact already with our county health services, that rolling out a kind of Narcan education, implementation, and distribution as necessary was seamless as it could be for something that is so scary, right? So we didn't see as much pushback as we may have thought, and but I'm not aware of any other places besides the nurse's office or like school health centers that Narcan is available at the school sites.
Yeah, that's what I've heard, is it's just in the nurse's office. And sometimes the nurse isn't there, or the nurse is covering 3 or 2 schools. And then also, I guess my understanding is it's only high schools, but maybe I'm incorrect. So it's every single school, all 33?
I believe it's required in all high schools. I don't believe it's required in all middle schools, but I'd have to check that to make sure.
I was just curious about thinking about families and parents and even educators. We've seen some stories on that. I don't know, it's just something that kind of I'm starting to think of as the years, as this continues, how we make sure that we cover all our bases for everybody who's in the school system.
Absolutely. And I am really excited about our new position, because that'll be on their task list of making sure that we are reaching populations that aren't in the immediate overdose demographic, and that we're trying to stay ahead of those trends.
Thank you so much.
I was just curious what Captain Schultz was saying, that he deals with this. Is that, were you saying, are people coming to jail on drugs? And then, I mean, you said you were dealing with it every day. I don't know how to say it. So, yeah, I guess you've told us, I think it was just our last meeting, how you're doing the medication, right, for them. But what are the problems that you were talking about that you're dealing with every day out at the jail?
People coming in unstable in booking that have swallowed medication or is hidden on them, and then they overdose in front of us.
And so there's no drugs, you know what I'm trying to say, people are not able to smuggle any drugs in though, right?
No, that's incorrect. Despite our best efforts in every in custody position, drugs get into every jail, every place, every school, despite everybody's best interests. And there's a number of ways to do that, body cavities. And sometimes they swallow it prior to going, and then they wait, and then they extract it out of them when they get into a situation. So it's a constant battle with it. You know, I was talking with the smaller pills, especially the fentanyl. The daily use now is 5 to 30 pills, is what we're seeing. You know, that's what our code detectives tell us. And it just seems for us, you know, we don't typically, they don't come into our system just based on a drug crime, or if they do for like distributing, they'll get arrested. Generally they get cited, or they go through our system and then they get released pretty quickly. But many of them are coming in with heavier charges, and that's what we're seeing. Our counts are still low, but it's not just a number of them. It's probably 80% that are being incarcerated have some type of addiction issue. Our MAT program now, you know, when I last talked a week ago, I think we had 10 to 15, we're at 25 now, but we did hire a nurse to assist. So our number on MAT is going up, and most of the time of the first time offenders are coming in and they're getting on MAT prior to leaving our jail. Some of them are coming in, they've already failed 1 or 2 times, which is okay, and they want to get back on the program and get through it. You know, my worry in law enforcement is we see many of the individuals, because in the day, mental health, the expert would tell us very few mentally ill people come to jail. Most of the mentally ill people follow their, you know, they have other issues to go, but they're not committing crimes to come to jail. But if you ask a police officer, they'll say everybody I deal with is mentally ill, and they all come to, because that's all when they get called, that's what they have to do. So now we're seeing the opioid use with the mental health stuff. And I'm glad Janice pointed that out, that clinicians, doctors are not treating them separately. It is one issue. Addiction is a mental health issue. But it just sets a big barrier for those who are mentally ill now, able to get these type of drugs that might want to treat themselves, into a point that it just sets them up for peer failure. So that's my worry, you know, and when it's incarcerated. But this is the issue we see with them. Most people come in jail are very, very vulnerable.
How are you keeping your nurses and your medical director on board? I'm kind of thinking they're getting burned out with this, or?
No, we have very Eden Aldrich is probably one of the best nurse practitioners I've ever met.
Yeah.
Our nurses are great. You know, pay is a big issue.
Yeah.
In the jail, they prefer, many of them prefer to work the jail than hospitals because they have us with them for security. Where in the hospitals, you know, they don't have, we've talked about this, the security in the hospitals is great.
Yeah.
And then they end up, you know, from there and then getting treatment or some service, and they come into us because they assaulted a nurse. We try to divert, but there's a point where you can't ignore the behavior. So no, they're doing great.
That's awesome. That's good to hear.
Okay, moving right along. I guess we gotta have approval of our October minutes. I always gotta get that in somewhere. Everybody read that? Yeah, good meeting last October, September. Really good meeting. Hey, somebody want to move for approval? Anybody?
I'll move for approval.
Thank you.
Second it.
There we go. That's taken care of. Okay, and announcements. Stole my thunders. Put it in the we're probably gonna cancel.
It's a reminder.
I know. But I don't get to announce it. You put it in the minute. You're in the agenda.
I always like hearing it though, so go ahead and say it.
We won't have this meeting in December. However, we will Jessica, need to excuse Jessica today because she's otherwise engaged, but Jessica and I and Dana and anybody else that wants to, that would, need your help. We're gonna go over what do we call it?
Year in review.
Yeah, the review of last year and some proposals and setting in agendas for the whole year, next year, things that are gonna be important. And so we'll be sending out some emails. We want email discussions and ideas on that, and we'll let you know somehow when we're gonna have these meetings if you want to come and be part of that planning process for next year. Anything else? Dana keeps notes on everything we say, so I don't remember anything.
You did great. That was it.
Okay. Jessica didn't have any notes of. Okay. Anything for the good of the order?
I'll just say that we got the keys this week to the North County Intensive Use Services Drop-In Center. And that's really, really cool. So Redmond campus is almost completely done. And Kristen and I will plan something for January for you all to come and see it. So anyway, it's pretty exciting stuff. So her portion of the building's done. Mine is so close, but we have the keys, so that's really exciting.
Shannon, do you have any, hello, by the way.
Hi, Christina.
Do you have any updates on any youth campus, residential?
No, we have a new contractor that we are looking at called Jackson House, but nothing to, report like, hey, we're moving forward. But we're looking at a different option than what we have in St. Charles, Deschutes County, Pacific Source are all involved in that effort. So
awesome.
There's a lot of momentum. Dr. Hafner is involved in it as well. There was a proposal to the governor, but the governor's office, they just didn't feel we were far enough along to receive any funding yet. So, but it hasn't slowed us down, a little bit of a delay, but we are really hoping to bring children's residential to Central Oregon. So
awesome.
Yeah.
Or just on that subject of youth, one of the things that I was making notes of this morning as I look, I get an email, and we talked about this last March when Dana McAllister was here from the System of Care. Youth, can't remember what all the acronyms are, but and I get through OHA an email every month called Holding Hope. It's really about those youth services. Just a ton of information in there and things that are going on around the state. I was going to print it out but it's like a 13-page document. So, and it's just their monthly newsletter and all the things that are going on. They have a warm line for families. Have mental health first aid for youth classes around the state going on and things like that. So just a whole lot of stuff. If you have especially an interest in the youth side.
So you can share that link with us.
The younger folks.
Yeah, what is it?
Yeah. I'll get to Dana.
I just email it. Thank you.
OHA Holding Hope, and then it'll give you a link to sign up to receive the newsletter. I just did it.
Sweet, okay.
So,
well, thank you, Roger. Yeah, I'll do that.
Just always impressed with how much OHA is doing on the youth side. That they mostly just have meetings on the adult sides. Okay. Thank everybody. Anything from the Metasphere? They call that now. So have a good Thanksgiving and Christmas, and look for emails from us, okay? And respond.
Thank you, everyone.
Thanks.